Participants, dear medical officers from Southern Railway Irhsa services. This is the initiative at the behest of our beloved PCMD, Dr. Murthy sir, CVN Murthy sir. He has given me instructions to hold online meetings at the zonal level on 4th and 5th Fridays of every month. So to begin with, I request our anesthesia department. This week we'll start with anesthesia department. Our anesthesia post TA PS graduate, Dr. Ammu, she has some interesting case presentation. And following that, Dr. Suganya from Pathology department, they have a very, very interesting pediatric case for case presentation. So without wasting much of your time, we'll proceed with the case presentation by Dr. Ammu. Over to Dr. Ammu. Dr. Ammu, you can unmute yourself. I will share your slides for Dr. Ammu.
Okay, so thank you, sir. Good afternoon, all.
Is the screen visible to all?
It's not visible to me, sir.
Is it visible now?
Yes, sir. Yes, sir.
Yeah, you can proceed, Dr. Ammu.
Sir, can you make it a slide? It's a slide view, sir. Slide show. It's not visible. Okay, thank you, sir. Good afternoon, all. It's a story of 50-50. Its name is a bit interviewing. By the end of the meeting, by the end of my presentation, I hope you will get to the point of what is 50-50. I'm Ammu. I'm doing secondary DNB first year in Southern Headquarters Hospital. Finished my DA from PSG Institute of Medical Science and Research, Coimbatore. So next slide, sir. It's an incident report. It's an 88-year-old male patient, known case of DM for past 30 years, systemic hypertension for past 30 years, and coronary artery disease. He has undergone a percutaneous thrombocatheter angioplasty for past, and he is on medication for past 30 years. He is taking medication for DM and hypertension. He came to casualty with failed passing of micturition. So they attempted a catheterization. The catheterization failed. So they planned for a suprapubic catheterization under local anesthesia in OR. And suddenly there was a call. We were in the OT and called over to the OR to see the patient, and they were complained of tachycardia suddenly for the patient. From a heart rate of 90, it went up to 270. So as I reached the OT, my team reached the OT. We saw that the SpO2 is connected, patient is on the table. We checked the response, patient was conscious and responding. Suddenly there was only SpO2 monitor connected, and it showed a heart rate of 270. So we checked the plethysmograph, and if it is correct or wrong, it was correct only. So we connected the monitors, ECG and NIBP was put for the patient. And as soon as we put the monitor, we connected the O2 also. So ECG showed a monomorphic wide complex ventricular tachycardia. That time the patient's vitals were BP 140/80 mmHg, pulse rate was 265 per minute, SpO2 was 100% with O2 of 4 liter in Hudson's mask. There was no IV line secured for the patient, so we secured the IV line and defibrillator, and the crash cart was suddenly pushed to the OT, and we attached the defibrillator, and the diagnosis of VT, ventricular tachycardia, was confirmed. As soon as it is confirmed, as it is a monomorphic VT of heart rate 265, we decided to give an injection amiodarone 150 mg IV bolus. Still, after giving the IV bolus, the VT persisted, ventricular tachycardia. So we decided for a DC conversion, 150 joule shock delivered after sedation with injection fentanyl 100 microgram and injection midazolam 1 mg IV. The patient was mild sedated. Monitor showed after the shock was delivered, the monitor showed an RF complex with a rate of 170 per minute. So it was changed from a ventricular tachycardia to a supraventricular tachycardia. So as a first method, we initiated a carotid sinus massage and we loaded a beta blocker, injected metoprolol 1 mg per ml, and we given 1 mg after 2 mg total undivided doses, and adenosine was prepared as the next measure. By the time the metoprolol was given, the rhythm again changed to VT. Suddenly the SVT in the monitor changed to ventricular wide complex ventricular tachycardia with a rate of 200 per minute, and the vitals were BP 100 bar 60 mmHg and SVO2 was 100%. Patient was responding. So we decided for another shock since the BP was 100 bar 60. Sir, next slide, sir. And so decided for another shock of 150 joule conversion, shock delivered, and as soon as the shock was delivered, the VT reverted to sinus rhythm. We came to know that by the vitals were 118 bar 70 mmHg and pulse rate was 84 per minute and was regular. SVO2 was 100%. And it was confirmed by the defibrillator rhythm. The VT is not no more. It is a sinus rhythm ECG was coming up in the ventilator. The fun was all these chaos happened and we always very tensed because it is an 88-year-old male patient. Anything can go wrong anytime. So we are all prepared. But the moment everything was settled and everything was okay, the patient asked me a question, Madam, 50-50 biscuits apple lama. I was really, that was really nice. And he didn't understood the seriousness or depth of the situation that he is going through, and I felt happy in a way that is he has gone through all these things without knowing what is going on with so many people around him and doing all these things. So the patient was shifted to ICU and we were stable. The procedure was done successfully and a cardiology call was given. Thank you. Lessons learned was no procedure under LA, local anesthesia should be done without monitoring, and a patient IV cannula, patent IV cannula, at least a minimum monitoring of ECG, SpO2 and BP to be done. Every OT should have an easily accessible and available crash cart with emergency medicine and defibrillator. Since all these things were available with me on hand and I had a competent team, I could manage the VT without any harm to the patient. Thank you.
Thank you, Dr. Ammu. Thank you. Now the session is open for questions. Any questions from the participants? If there are no questions, can we move on to the next presentation? Bhaskar sir, can we move on to the next presentation, sir? Hello, am I audible? Hello?
Hello.
Am I audible, sir?
You are audible.
Yes, sir. Any doubts from the participants? Thanks, Dr. Ammu. It was a wonderful presentation of a very rapid response provided by our team of anesthesia, and lessons are very, very clear. Any procedure, mild, moderate, or severe, or just local anesthesia or vocal anesthesia, whatever it may be, any procedure being done on a patient, it is a vulnerable situation and anything can go wrong due to any factor. So it is always very mandatory to have an IV line available with patent IV line for the patient, so that if there is a problem, they can respond with appropriate drugs in case drugs are available. But the drug should be available and equipment should be available in a readily available and working crash cart. And most important thing is minimum basic monitoring facility should be provided. There are two standards by American Society of Anesthesiologists for minimum mandatory standards. Standard 1 says there should be a qualified anesthesiologist who can monitor the patient throughout the procedure, and in case there is anything abnormal, immediately respond to the situation accordingly. And Standard 2 provides for minimum monitoring of pulse rate, blood pressure, ECG, and oxygen saturation. And nowadays they have included the end-tidal carbon dioxide also, along with temperature and urine output monitoring in case wherever it is relevant. Thank you. Thank you for the wonderful presentation, Dr. Amu. And we'll move on to the next presentation by Team Pathology from RS Perambur. Over to Dr. Suganya.
Good afternoon, and all. We are here to present an interesting case of a 7-year-old boy who presented with fever, generalized lymphadenopathy, hepatosplenomegaly, and the patient was evaluated by pediatric department of Railway Hospital, Perambur, and they have had a close interaction with us to establish the diagnosis. I would like to thank Dr. Nivedita Madam and their team for establishing a proper diagnosis and proper treatment for this patient. Sir, can you share the presentation? Sir?
I'm sharing the presentation for you, Dr. Suganya. Okay, you have already shared.
You can start. You can start the presentation. You can start.
Good afternoon, everyone. I'm Dr. Manisha, first year DNB resident, Railway Hospital, Perambur. I'm presenting a case of a 7-year-old school-going boy admitted on 28 February with chief complaints of fever for 12 days, neck swelling for 4 days, vomiting for 2 days, and poor oral intake since 1 day. Child was apparently normal 12 days back when he developed high-grade fever, which was intermittent, rigor, not associated with rash, which was relieved with medication, and there were no specific aggravating factor. And also had history of neck swelling noted for 4 days, which was insidious onset, progressive, associated with pain, not associated with any breathlessness or difficulty in swallowing. He also had history of vomiting and history of poor oral intake. So the child had been treated on OPD basis at outside hospital for the above complaint. He also had sore throat, headache, abdominal pain, which was localized in the right upper quadrant, dull aching pain, no radiating, but no specific aggravating or relieving factors. History of myalgia also present, no other significant history. So developmental history and immunization, the patient had attained age appropriate milestones, and immunization also immunized up to 5 years of age. On general examination, patient conscious oriented, sick looking, pallor present, no icterus, no clubbing, cyanosis or edema. Lymph node examination, there were submandibular, middle, deep cervical regions, which are firm, discrete, mobile, with maximum size of 2.5 to 2.5 into 2 centimeter. And there are bilateral apical axillary lymph nodes palpable, 1 into 1.5 centimeter. Epitoclear suboccipital nodes are also palpable, and bilateral inguinal nodes are also palpable, 2 into 2 centimeter. So image showing is bilateral cervical lymphadenopathy. So coming to vitals, pulse rate was 124 per minute, respiratory rate 32, blood pressure 100 per 60 millimeters of mercury. Patient was febrile with temperature 101.3, and oxygen saturation was also normal, 99%. Then examination, there were periorbital puffness. On throat, there's pharyngeal congestion and no exudates over the tonsil. Bilateral grade 3 tonsillar enlargement was there. Respiratory system examination is otherwise normal. Coming to upper abdomen, it was soft, non-tender. Liver is palpable 7 centimeter under right costal margin. And there is also splenomegaly, which is palpable 5 centimeter towards the right iliac fossa. No shifting dullness or fluidal. Then cardiovascular system, S1, S2 heard, no murmurs. And CNS, no focal neurological deficit. When on further evaluation, MAN2 test was done, which was negative. Sputum CB NAT, Mycobacterium tuberculosis, not detected. Chest X-ray also shows normal study. Then USC abdomen showed liver of 12.7 5 centimeter with multiple paracaryotic nodes and multiple enlarged nodes, which is present in right iliac fossa. So summary, a 7-year-old school-going male, vomiting, poor intake with headache, sore throat, myalgia and abdominal pain. On examination, pallor present without icterus, without rash, and there were generalized lymphadenopathy, periorbital puffness, pharyngeal congestion, grade 3 tonsillar enlargement with hepatosplenomegaly. So the clinical diagnosis considered are differential diagnosis, infections like tuberculosis or infectious mononucleosis, or it can be malignant hematological malignancies, leukemias or lymphoma. Coming to investigation, the complete blood count done on 20th February showed hemoglobin 8.6, WBCs increased up to 45,600, platelet 3,32,000. Peripheral smear examination, RBC showed microcytic hypochromic with mild anisocytosis. WBC, there were absolute lymphocytosis. It was around 31,800 with atypical lymphocyte constituting around 18%. Platelets were adequate. Many large platelets and platelets clumps are also seen. No hemoparasites identified. So the impression was atypical lymphocytosis and microcytic hypochromic anemia. So here we can see, we can compare with the normal small mature lymphocytes on the right side. So in this peripheral smear, the picture is showing atypical lymphocytes, which are large cells with moderate to abundant cytoplasm. Some were vacuolated, some are showing cytoplasmic granules, and nucleus is also enlarged with irregular borders, and some are indented. Atypical lymphocytes are seen. And serological tests showing dengue, NS1 and IgM was negative. Salmonella typhi IgM is also negative, and this antigen IgM found to be positive. On follow-up, the complete blood count on the March 2nd, it was hemoglobin 8.5, W 100, platelet level, and peripheral smear again showed microcytic hypochromic anemia, but there were reticulocytosis also been there, and lymphocytosis with atypical lymphocytes reduced mildly to 14%. So final diagnosis was infectious mononucleosis. On follow-up, patient was treated. He improved symptomatically, no further fever spike, and splenomegaly was persisted even on discharge. Coming to the topic infectious mononucleosis, it is a benign self-limited lymphoproliferative disorder, more common in adolescents and young adults. It can also be seen in children, also known as kissing disease or glandular fever, transmitted by saliva. 90% of infectious mononucleosis is caused by EBV, 10% by cytomegalovirus, HIV, toxoplasmosis, rubella, adenovirus, hepatitis viruses, etc. Incubation period is around 32 to 49 days. So common symptoms, systemic symptom, patient can present with fever with chills associated with lymphadenopathy, and splenomegaly, and can also have other symptoms like fatigue, loss of appetite, headache, photophobia, sore throat, and then tonsillar enlargement with white patches. Coming to pathogenesis of infectious mononucleosis. So this Epstein-Barr virus first attaches to and infecting the epithelium of the throat, where it replicates, where it is entering into the lymphatic vessels and blood vessels. So virions which are entering into the lymphatic vessels are carried into the lymph nodes, and some of the virions escape the lymph node trap and are carried into bloodstream also. So virions which are attacking specifically in the lymph node to the B lymphocytes and infecting them, either it may produce a latently infected B cells or productively infected B cells. So these productively infected B cells were actively replicated and differentiated into cells producing random immunoglobulin, including heterophile antibody. So in our body, in an immunocompetent person, the activated T cells will attack these productively infected B cells, and these actively infected cytotoxic T cells we are seen as atypical lymphocytes in peripheral smear. But the latently infected B cells are which are seems to be immortal because which cannot be attacked by these activated T cells. One more slide. So coming to the evaluation of Epstein-Barr virus replication EBV specific antibodies measured by enzyme immunoassay during primary infection. So may not be detected in the blood, but it's usually found in large quantities in the oral cavity. And the virus is cleared from blood much more rapidly than from the oral compartment also. The oral virus shedding can persist for months and occurs intermittently for years in most healthy adults. At the onset of illness, most patients have this IgM antibodies to this Epstein-Barr virus viral capsid antigen. This will decline between 2 to 6 months after the infection. This viral capsid antigen IgG antibodies are detected as early as first 2 weeks of illness, and in essentially 100% of the patients can have this detectable viral capsid antigen IgG antibodies during convalescence, and they persist for life. And this Epstein-Barr do not develop until 6 months after the infection, but once developed, they persist for life. So when a patient 10 to 30 years of age with sore throat, palatal petechiae, posterior cervical or auricular lymphadenopathy, or marked axillary lymphadenopathy or inguinal lymphadenopathy, we can suspect infectious mononucleosis. Then first we will do heterophile antibody testing. Then if it is positive, diagnosis of infectious mononucleosis is considered. Then we can give symptomatic treatment for infectious mononucleosis, and we can also do a rapid test for group A beta hemolytic streptococcus pharyngitis. Then antibiotics are only given if this test is also positive. So if the heterophile antibody test is negative, we can do complete blood count with differential. So if it is showing absolute lymphocytosis, that is absolute lymphocyte more than 4,000 with more than or equal to 10% of atypical lymphocytes, then antibody test for viral capsid antigen IgM antibody should be done. Then if it is positive, diagnosis of heterophile negative Epstein-Barr virus infectious mononucleosis is confirmed. If that test is negative, we can consider heterophile negative mononucleosis like illness. So if the complete blood count is showing absolute lymphocyte count is less than 4,000, reconsider our diagnosis. Coming to treatment, good supportive care including adequate hydration should be given. NSAIDs or acetaminophen for fever and myalgia, throat sprays or gargling with 2% lidocaine solution to relieve pharyngeal discomfort. And corticosteroids are recommended in patients with significant pharyngeal edema that causes or threatens respiratory compromise. Complications are upper airway obstruction from massive lymphadenopathy, splenic rupture, autoimmune hemolytic anemia, pancytopenia, hemolytic uremic syndrome, episcleritis, uveitis, and erythema multiforme. Coming to splenic rupture. So the risk of splenic rupture is estimated study around 8 patients. So in a review of 34 out of 55 athletes with splenic rupture, almost all ruptures are occurred on the first 3 weeks of illness. Interestingly, in the same series, 1/2 of the ruptures were atraumatic. So these data suggest that patients should be kept out of athletics for at least 3 to 4 weeks and until they are asymptomatic. Some experts also suggest a longer duration of restricted activity for 5 to 6 weeks or even 6 months. Infectious mononucleosis should be suspected in patients 10 to 30 years of age who is presenting with sore throat and significant fatigue, palliative peritone, post axillary adenopathy. Corticosteroids, acyclovir, and antihistamines are not recommended for routine treatment of IMN. Atypical lymphocytosis of at least 20% or atypical lymphocytosis of at least 10% and lymphocytosis of at least 50% may signal infectious mononucleosis. The corticosteroids may be helpful in patients with respiratory compromise or severe pharyngeal edema. And patients with infectious mononucleosis should not participate in contact or collision sports for at least 4 weeks after the onset of symptoms and until they are asymptomatic. That's all. Thank you. Thank you, everyone.
Thank you, doctor. Thank you, Dr. Suganya. It was a nice, extremely beautiful and very useful, informative presentation. Now the session is open for questions. Any questions from the participants? The participants can even type their questions in the chat box. Dr. Suganya, you want to add on something to this presentation? Kindly unmute yourself.
That's it, sir. Like if the patient is around 10 to 30 years with enlarged neck nodes and inguinal nodes or abdominal nodes, lymphocytosis in the peripheral smear, they should consider a possibility of infectious mononucleosis with they can advise peripheral smear examination to look for atypical lymphocytes. And because this may be mistaken for any leukemia in some unexperienced, they may label this lymphocytes as atypical lymphocytes as blast. That may result in misdiagnosis. So appropriate investigation in these patients will help in establishing the correct diagnosis. That's it, sir. Thank you.
Yeah, thank you, Dr. Suganya. It's a wonderful take-home message. Just having multiple lymph nodes, enlarged lymph nodes with abnormally looking malignancy-like looking peripheral smear lymphocytes, one may tend to give a diagnosis of leukemia or lymphoma, but that will spell disaster in the patient's life, that too in the most productive age group of 10 to 30 years. Even though wrong treatment may be initiated at times, it's always better to take a second opinion before giving a very sinister diagnosis like a malignancy. So this lecture would have been really very informative for all our participants. So whenever you have a doubt, always consult the expert in the field and take a second opinion before spelling a sinister diagnosis for the patients. Thank you. Regarding this program, PCMD sir guided me that we will have, every month we will have Friday clinical meetings, and the first Friday and second Friday will be clinical meetings in physical form in the concerned divisions and RH Perambur, and the clinical departments will be conducting the meetings at their own level. And the third week will be at zonal and division levels for the clinical and medical audit meetings. So last week we had a very informative, wonderful clinical audit meeting wherein Dr. Musharat has presented 2 important cases, and they were very successfully revived. The patients were given best of the treatment. One patient had liver failure and they succumbed to his illness despite our best efforts. And the second case had a surgical problem, and the patient was successfully managed within with a very rapid response in the surgical way, that within 3 hours of admission, our laboratory was able to provide accurate and very important laboratory reports. And our anesthesia team also resuscitated the patient, with the elderly patient with intestinal obstruction and gangrenous hernia, and the patient was operated. He had a perforated appendix also. So the case was successfully managed by our surgical team also, and the patient was successfully discharged and he is doing well now. So such important clinical activities carried out by us should be well projected and recorded so that our effort is well being recognized by all the fraternity as well as the administrators as well. So I hope this clinical meeting has been received with due importance by all our colleagues. So kindly spread the message to other colleagues who are busy in their other clinical and routine activities also, so that they can also spare their time. And our clinical meeting on zonal level will be conducted on every fourth Friday of every month. So this being the fourth Friday, in some case we have a fifth Friday also in a month. That will also be online meeting, and all the zones and the entire zone with the RS Perambur headquarter and divisions can participate with their clinical staff. So it is been instructed by PCMD that we will make a schedule of departments. This week we had Anesthesia and Pathology department. Next month on 22nd April, being the fourth Friday, we will have 4 topics. One will be by Dr. Gandhi, King Gandhi from RH Perambur on a urology case, and next will be Dr. Raghavendra on a medical gastroenterology case. And one topic will be on the medical manual related items, clinical topics from Trivandrum, and the fourth will be from Dr. Frank Aman from Palakkad division. So this is for now, and we will meet again on 22nd April, the same time. Till then, goodbye to you all. Thank you. Any more comments from our participants, please? Can we sign off this meeting, sir? Thank you, sir. Thank you.
Thank you.